Well, welcome to the March edition of our Johns Hopkins Center for Health Equity Jam session. We're excited that that all of you have tuned in, and we are super excited about our guest today, our guest speaker. And you were listening to some music that was recommended by Dr. Ravenell, who told us that he likes 90s hip hop music. So that was a selection that we found that could fit perhaps that didn't have as many expletives as some of the 90s music that some of us enjoy. But I hope you enjoy that. We're going to learn about how to live forever young, perhaps via some of the work that he's done as well. So we're going to get started here with our traditional approach, which is going to be to learn about some fun facts about our guest speaker today. We're going to do it in the form of a quiz. So everyone get your chat feature ready. And let's see, we've got some really fun ones. So Dr. Ravenell has 4 children, and they are serious athletes, it seems. So the first thing that you all can guess in the chat is the number of sports championships that his household can boast of. It's an easy one. Just throw out your favorite number. Okay, I see 14. I like it. Nicole, 20. Okay. So actually, so far the correct guess comes from one of our center's greatest athletes, actually, Dr. Matthews, who's quite a track star, who guessed 7, and that is correct. She was at least the first to guess 7. So Joe, do you want to tell us more about these championships?
Yes. So it's such a pleasure to be here. Let me just say, and I'm glad so many people share my taste in music. And so when I'm not being a doctor or a researcher, I love coaching my kids, and so I've had the pleasure of coaching all 4 of them, and between league championships and town rec championships, we have 7.
Awesome.
4 of those are in basketball, 1 in baseball, and 1 in lacrosse. So
amazing. That's great. And you're doing you do the coaching for which ones? All of them?
So I coach basketball. Those who can't play coach. So
terrific. All right. So our next quiz question is so in a previous lifetime, Dr. Ravenell enjoyed, let's see, one artistic expression that it sounds like he was quite good at. So let's take some guesses in the chat. Bass player. I like it. A rapper. All right. 90s rapper. That's why he likes 90s rap music. A painter, a poet. Everyone thinks you play an instrument. Okay, it's our very own Nancy Edwards Malello. who guesses singer. Do tell us about your singing.
Yes. So in a previous life, I was a singer. I was actually classically trained as a young person. So I grew up in the Black church, and I'll talk about that a little bit later. But for those of you who can relate, particularly if you are part of a small congregation, you do everything. So you're on the usher board, you're part of the choir, you even on Saturdays are part of the janitorial board. And so one of the many things that I did in my church was to sing in the church choir, and that got me started. I then auditioned for a school of the arts had lots of wonderful opportunities that culminated when I was 12 with a performance with Sarah Brightman, and we were singing to Andrew Lloyd Webber's Requiem, which was a ballet choreographed by the American Ballet Theater, headlined by Mikhail Baryshnikov, and it ended up in 1986 at the Metropolitan Opera House, and there is
Wow.
footage somewhere of me being interviewed by Jane Pauley on the Today Show, talking about
Whoa.
it.
The first
So
person that can find that video and place it in the chat, we'll send you a gift. So, amazing. Well, you gave away our final clue, but I was and someone in the chat, Deja Love Hartnett, did actually share this too. But I was gonna share that that our guest today is a PK. Who wants to tell us what a P? Who other than Deja? Who wants to tell us what a PK is? Yeah. So,
Yes. So one of the very proud parts of my identity is being a preacher's kid. Both my parents were ministers. My mom passed away a couple of years ago, but I also have grandparents on both sides who were ministers, and I have two brothers who are ministers. So going into medicine and not donning the cloth, I am the black sheep of the family. So. But no, but that identity has really influenced my work in many ways. But I do feel like what I do is not only a career but a calling. So.
absolutely, and I think Lisa said it best, that you're a minister in many other ways. So that definitely fits, and I can identify. I'm a deacon's kid with a lot of ministers in the family. So definitely can relate. So wonderful, and thanks to all for playing along. So I want to provide a little bit more of a formal introduction of Dr. Joseph Ravenell, who is an associate professor of population health and medicine with tenure and associate dean for diversity and inclusion at the NYU Grossman School of Medicine. He's a proud primary care physician and a health equity research scientist. And Dr. Ravenell has led multiple federally funded clinical trials to test various community-based strategies to improve colon cancer screening and cardiovascular disease prevention among Black men throughout New York City and beyond. And his work has engaged a community-based research network of over 200 sites, including churches, barbershops, mosques, and social service agencies, reaching over 20,000 New Yorkers. Dr. Ravenell's community engaged work was the subject of an invited TED Talk, which has received over 1 million views. So that's another thing for us to drop in the chat for you all to listen to later or to watch later. And he continually cultivates a holistic approach to promoting health equity through research, scholarship, and mentorship. And I first met Dr. Ravenell about 13 years ago when both of us were Amos Medical Faculty Development Program scholars. I think you were about 2 years ahead of me, I think, and more recently collaborating on the American Heart Association Restore Network, which several of us are involved in, and Joe leads a project of. So we are thrilled to have you join us today and really look forward to hearing about your work. Welcome.
All right. Thank you so much, Deidre, and just really grateful for the invitation. I want to recognize some of the incredible folks at Hopkins that I have long known, including Dr. Lisa Cooper, who is one of my sheroes for sure. And then also want to recognize Dr. Yvonne Commodore-Mensah, who is an investigator in the Restore Network. So I'm going to share my screen and just to talk through a little bit some of the work that I've done related to health equity and Black men's health. but I think also I'm going to talk about some of what we're doing with the Restore Network. I am happy to answer any questions that you all have. One of my virtues is I am honest to a fault. So whatever you want to know, I will be super honest about it. And I think it's important for, for those of us who do health equity and health equity research, one of the problems with research is people are not honest enough about challenges. And so I'm more than happy to answer any questions that you have, because at the end of the day, I think we all win, when we have a true sense of what some of the issues and challenges are. So I'm going to start by just getting us on the same page about what I mean by health equity. I'm sure everyone is very familiar with this definition provided by the Robert Wood Johnson Foundation. It's one that to me, it's in plain English, plain language, and really covers what health equity means to me. Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And a related concept that I think all of us think about is health justice. And health justice, I think, takes health equity a step further. And these are some reflections about health equity. I'm sorry, about health justice. Health justice means health equity, dismantling the effects of racism and working towards sustainable policies and innovations that will last through generations. Health justice is also equal access to health information and care, and equal protection under the law to ensure a healthy and safe environment. And lastly, health justice is a collective concept that should be considered a fundamental human right. So with that, I will jump into this slide, which I have been showing for almost all of my career. And sadly, it has not changed much. Hypertension, as we know, disproportionately impacts Black people. And when we talk about mortality from hypertension, it really disproportionately impacts Black men who have the highest mortality rates from hypertension. The reason that hypertension is so deadly is because there are several barriers for men not only learning about their blood pressure, but controlling it. And so if we look, this schematic here just shows sort of what it takes for men with high blood pressure to get their blood pressure controlled. So it historically takes, getting connected to a healthcare provider or healthcare site, and then where there is a healthcare provider who can make the diagnosis, but also provide therapeutic recommendations, which generally include a combination of lifestyle and or medication. That is, of course, just step one. Step two is the patient has to be able to actually follow those recommendations, which includes, having access to things that can facilitate a healthy lifestyle, like healthy food, like safe neighborhoods with with reasonable walkability. Not to mention the other competing priorities that can get in the way of all of those things. And so it's not a straightforward process. And when you layer on top of that barriers such as decreased health care seeking behavior due to competing priorities, and then long known barriers of cost and, of course, access and medical mistrust, getting from here to here can be quite challenging. thinking more deeply about the access challenge. This is data from the Dallas Heart Study, data from probably about 15 years ago. But this basically demonstrates that among 1,600 hypertensive citizens of Dallas, Texas, Black men were the least likely to have a primary care provider. And when we delved into that, the biggest contributor to that was a perceived lack of a perceived lack of need for a primary care doctor. We heard several times that basically, if I don't feel anything, if it's not causing me pain, if it's not preventing me from going to work and taking care of my family, I don't really need to go and get it checked out. And so we realized from this work that that addressing that perception was probably an important part of the story. And so we started to think about, what are the ways that we could actually connect with Black men to try to address the perceived lack of a need for addressing hypertension or other primary care sensitive conditions, and combining that with the data that we saw on the previous slide of lower likelihood of engaging with primary care, we decided to look outside of the healthcare setting to figure out how we could connect with Black men. And the Barbershop is a place where we know we can reach Black men. Speaking from experience, it's a place that we go often when time permits. I try to go every 2 weeks and take my boys with me. Time no longer permits, so I was very fortunate to have had the opportunity to go get a haircut yesterday. Otherwise, you would have seen a much wolfier doctor. But it's a place where we go not just where we can where we know that we will come out looking better than when we came in, but it's a place where we will be fulfilled in several other ways. It's a place where we go for camaraderie, a place where we go to connect with people who are essentially living a similar struggle. And of course, it's a place where we can connect with our barbers. And what we learned from our formative work was that men on average are with their barbers for 7+ years. And so that's a long time. If you can imagine 7 years of seeing someone every other week, you can imagine the type of friendship and relationship that can be built in that time period. And so we really thought long and hard about how we could partner with this important institution. And the importance of the barbershop really, goes back to the days of Jim Crow, as well as, back to the times of the enslavement of Black people, where barbers have had a role as community leaders, and barber shops have been a place of information exchange, a place where, again, there was trust, there was camaraderie, and a place where you knew you were safe, safe from the challenges of the outside world. And for those, for that 30 to 90 minutes, sometimes longer, depending on what day of the week you go. It really is a place of refuge for many of us. So back in the early 2000s, I went down to Dallas, Texas, to work with a group who was really looking to really deepen this idea of how we can partner with barbershops as detection and follow-up centers for Black men with regard to hypertension. And I saw in the chat someone referencing the spirit of Dr. Eli Saunders, and I thank you for that. He too is one of my heroes and one of a handful of pioneers who really advanced community-based health promotion related to hypertension. You know, going back to the 1960s, when the American Medical Association demedicalized the measurement of blood pressure, it was in large measure in response to the advocacy of people like Dr. Eli Saunders and several others who said this problem of hypertension is resulting in a stroke rate that is 900 times higher among Black men compared to white men. And if we just leave it to the healthcare profession to help address this challenge, we're never going to get there. So we really need to empower communities to start to measure blood pressure and increase awareness of hypertension. And that was when community-based health promotion and measurement of blood pressure in churches, in schools, and in barbershops really started. And so this idea of measuring blood pressure in the barbershop is really back to the future. And I am happy to say that I had the pleasure of meeting Dr. Saunders, and he was a really important consultant on this early work in Dallas, Texas. And so the idea that we really wanted to develop and test was to see, could we measure blood pressure and have blood pressure measuring be a sort of regular part of the visit to the barbershop. As I mentioned, you can be there for a while, so why not make use of that time and sort of leverage what is incredibly special about the barbershop, which is it's a place where we're comfortable and a place where we talk about things that are important to us. And contrary to what many people think, health is actually very important to Black men. And so this idea of talking about blood pressure is something that whenever we would go into barbershops and let them know about what we were thinking about doing, we were largely embraced because it was very much aligned with what they thought could be successful in barbershops. And so the idea was that as men would come in, sit down in the barber chair, and we would essentially sort of utilize the usual routine of getting your haircut, which is that you go into the chair, you sit down in the perfect blood pressure measuring chair. So I don't know if you've ever looked at a barber chair, but it's absolutely perfect for measuring blood pressure. So the American Heart Association recommends that when you're measuring blood pressure, that you rest for at least 5 minutes, that you sit in a comfortable chair with your arm at heart level and with your back supported and both feet flat on the floor. So a barber chair has armrests that are perfectly positioned. It's a comfortable, fluffy chair, and it has a sort of footstool to allow you to support both of your feet. So the barber chair is the perfect blood pressure measuring device. And as you can see here, this is an automated blood pressure machine. This picture was taken probably about 20 years ago. And this at the time was a state-of-the-art monitor. And so you can see that this is a properly sized and properly placed cuff. And we actually trained the barbers on how to position their customers, how to wait at least 5 minutes, and essentially they just had to press start. And this machine would take 3 readings and record them, and then give an average. And we actually worked with barbers on essentially how to counsel their customers on going to the doctor if their blood pressure was high. And so step 1 is having the barber measure the blood pressure at every visit to make it part of the culture. Step 2 is interpreting the blood pressure and having the barber refer hypertensive customers for medical care. Ideally, what would happen is the customer would then go to a local doctor, and we ensured that we had folks who could navigate the customers there, and then ideally the provider would initiate therapy, and ideally the customer would actually begin that therapy and then go back to the barbershop in 2 weeks, which is a perfect time to sort of see how things are going with a follow-up blood pressure measurement. And the idea was to have this cycle enacted until we reached hypertension control, which at the time was less than 140/90. We know that things have since changed, but this model, we believe still holds. And so we actually tested this in a cluster randomized trial in Dallas, Texas. We started with 24 shops, 12 intervention shops, and 12 control shops. In the control shops, they were not getting this barber-based intervention. They were getting usual care, which was essentially printed educational materials. And what we found after following these shops for a year was that in the usual care shops, there was an increase in the hypertension control rate within each shop of about 11%, compared to the intervention shops, where we saw an almost 20% increase over that 1 year period in the hypertension control rate in the intervention shops. And so there was an intervention effect of about 9% when it came to hypertension control. And so this was absolutely terrific. This was a positive study. We saw a pretty significant intervention effect. What we were puzzled by at first was the significant increase in hypertension control that we saw in the intervention shops. And what we realized was, that these shops were not completely a usual care shop. And I apologize for the sirens outside of my window, the joys of living in New York City. So what we realized was these were not completely usual care shops, because there was actual actual blood pressure measurement happening, which we of course needed to do in order to be able to compare blood pressures in the control shops versus in the intervention shops. And what we decided was that having several months of just having your blood pressure measured actually constituted a pretty significant intervention. And so we think that that probably accounts for the increase that we saw. But nonetheless, there was still a greater increase and something for us to build off of with this study. And so that was sort of the beginning of my barbershop career, so to speak. Life happened, and then I was called to New York City, where this community here was really ripe for what we were doing in barbershops in Dallas, Texas. In fact, there was already some barbershop activity happening that not only involved hypertension awareness, but also there were efforts around diabetes, as well as prostate and colorectal cancer. And so that really gave rise to the Men's Health Initiative, which we started when I came here to New York City. I was recruited by my good friend and colleague, Dr. Benga Ogadegbe, and we are still working very closely together on hypertension prevention and control in communities of color here. And so with this Men's Health Initiative, this actually gave us the ability to not only focus on hypertension, but also to expand to unfortunately, some of the many other conditions that disproportionately impact Black men, including colorectal cancer. And it was here that we really started to think about the social determinants of health, and to really start to use a framework. And so this is one of the first social determinants of health frameworks that we used, and it's sort of a merging of a model that we found by David Williams, who is the sort of the true progenitor of racism and health. And then Dr. Mary Northridge, one of the previous past presidents of the American Public Health Association. And so what we have here is, at this end here, we have health outcomes, then we have sort of proximal determinants, intermediate determinants, and macro determinants. And health behavior, we know, is definitely, when we think about, what are the immediate sort of steps before health outcomes, it really is behavior, whether it be lifestyle, therapeutic lifestyle changes, whether it be cancer screening, whether it be medication adherence, whether it be healthcare use. We're talking about a series of health behaviors. We know that there are several influences on those health behaviors that include these intermediate determinants that are basically one level up from health behaviors. But these intermediate determinants include stressors and survival needs, such as financial insecurity, housing and housing insecurity, occupational considerations, neighborhood, of course, and unfair treatment, and then things much more sort of in our wheelhouse, such as medical care. All three of these need access and quality. Psychological resources, right? When we think about Maslow's hierarchy of needs, and then social resources. But we know that these intermediate determinants are all influenced by these macro determinants, which I don't have to tell this audience. In medicine, we have historically not focused on these as much, I think largely because we have felt like these are out of our control, but we have learned in some incredibly real and stark ways that we cannot ignore these macro determinants, and if we do, it is at our own peril and the peril of our patients. But right at the top of the list is racism, and it really does influence all of these other macro determinants, from the original sin, so to speak, of the enslavement of Black people. So this again is when we really started to seriously think about what we're doing in terms of a social determinants of health framework. And as I mentioned, because of everything that was happening in New York City, it gave us the ability to expand what we were doing, from just focusing on hypertension, but also to focus on other important public health conditions, such as colorectal cancer. And this slide depicts that the mortality from colorectal cancer is about 50% higher among Black men compared to white men. And if we look at this diagram that I created for hypertension, you can draw a very similar one for colorectal cancer and colorectal cancer screening, where if we take men who are unscreened but eligible, right? It generally takes getting connected to a healthcare provider or system. It takes that provider making an appropriate referral. At the time here in New York City, colonoscopy was the gold standard for colorectal cancer screening. We have since expanded to some of the newer methods that we have, and here in New York City, as I'm sure we have more broadly, we definitely believe that the best test is the one that gets done reliably and safely. But of course, in order to get from the referral to actually getting follow through and getting the screening completed, often there is a lack of navigation that is a huge barrier here, because as difficult as it is to go to the pharmacy to pick up your antihypertensive medications, it's even more difficult to actually schedule an appointment at a colonoscopy suite to get the prep and to be able to afford both of those. We know can be a significant challenge. And so navigation to the test that the person can afford and that basically aligns with their life situation, with their job situation, that often takes a level of navigation that patients are often not able to acquire on their own. And so we decided to focus on these barriers in trying to improve colorectal cancer screening among Black men. These are just some images from our work in the community. We had a mobile van where we did much of our work that we would basically park outside of barbershops or churches, bring people into the van, screen them for hypertension, diabetes. Once upon a time for prostate cancer, right there on the van, and then be able to refer them for colorectal cancer screening. So this slide here depicts basically two concurrent studies that we had at one point, focused on both hypertension as well as colorectal cancer screening. That really was the basis for the Men's Health Initiative. So to just delve a little bit deeper into the patient navigation intervention, basically, we were very fortunate to recruit several community health workers from the communities where our barbershops were located. And those community health workers, they served as patient navigators. And so we basically placed them in the barbershops where they sought to identify men who were eligible but unscreened. And so part of what they did was first to educate on the disproportionate risk that Black men have from colorectal cancer and the need for screening, and then to elicit barriers, right? And so, what are some of the reasons that someone who is eligible, was not yet screened? And in addition to logistical and financial barriers, there were also attitudinal barriers. And so, really helping folks to move along the stages of change spectrum was a big part of what these navigators did, and they did it brilliantly. So the idea was in the first session to cover these points here, and then in subsequent sessions, depending on what the barriers were, to try to address each of those to really get to the point of getting the men to accept an appointment for colonoscopy, or to accept a stool kit to be able to do stool-based screening, and really not only to just help them set up the appointment, but literally to navigate them to where they could go for what they could afford, to make sure that they could get the prep, and then to make sure that they actually got to the screening facility, made sure that they had an escort. If we encountered a customer who, for whatever reason, was not connected enough to be able to identify an escort, our navigator served in that role. And importantly, the navigators actually checked in after the screening to help with any necessary follow-up. And so with the Men's Health Initiative, we worked with over 200 community-based organizations over that 6 or 7 year period. This is a map showing that we were in all 5 boroughs of New York City. And this is a table 1, so to speak, of the men that we enrolled in our study and who were part of the Barbershop trial. So on average, they were 55 years of age, which was actually right in the sort of target zone that we were going for. In some of the formative work that we did, we learned that in New York City, on average, the men who were getting colonoscopies were closer to the age of 65, which we thought explained a lot of why men were being men when they were diagnosed at much later stages. And so one of our goals was really to try to identify younger at a younger point in the sort of screening eligible period. And this tells you about the education. The majority were born here in the US, but we actually had a significant number who were born outside of the US. The majority spoke English at home. And this tells you that that many of our men were disconnected at the time that they were enrolled in our study. As well, a fairly economically disadvantaged group where many were out of work for a significant period of time, and annual household income, pardon me, of $17,000, which you can barely live a month in New York City on $17,000. And then a very high smoking prevalence of people who currently use tobacco products. So this was another successful study. Basically, we found that for those who were exposed to patient navigation in the barbershop, that they were twice as likely to get screened over a 6-month period compared to those who only got a recommendation from their doctors. And the difference remained after adjusting for important covariates such as education, health literacy, insurance status, having a personal doctor, neighborhood factors such as neighborhood poverty, and neighborhood segregation. A subsequent analysis compared those who received our intervention to those who truly received usual care and really received and got no interventions in our study, and the odds ratio for getting screened was nearly 4. And so we were really thrilled to publish this work in American Journal of Public Health, and really grateful to all of these different entities who contributed to this study. And so while we were advancing work along the colorectal cancer front, my mentor with whom I started in Dallas, Dr. Ron Victor, who passed away a couple of years ago, he went out to California and really refined the barbershop model and sort of built on what we had done in Dallas, and built on the extensive literature demonstrating the impact of or potential impact of pharmacists on medication management and hypertension management. And so what Ron and his team did was to actually, in addition to measuring blood pressure in the barbershop, they actually brought a pharmacist on site who would actually come to barbershops once or twice a week. And rather than have the barbers sort of do the majority of the counseling, really what the barber did was to refer the men to the pharmacist, who would then sort of take over counseling about medications, and importantly, making sure that an immediate connection was made in order to get men who needed it started on antihypertensive therapy. And so with that really important addition to the sort of team of people who are working to improve hypertension, in these Black barbershop patrons, it really ended up with tremendous results and was published in the New England Journal of Medicine shortly before Ron Victor died. He was able to see his sort of lifelong dream of having this work published in the New England Journal. He actually got to see it happen. And so what they were able to demonstrate was that bringing a pharmacist into the mix in the barbershop, as opposed to where pharmacists usually operate more in pharmacies and healthcare settings, bringing them into the barbershop actually resulted in a tremendous intervention effect over compared to control. They looked at systolic blood pressure, and over the 6-month follow-up period, they saw a 20-point drop in systolic blood pressure, which of course made really which made huge headlines, because this is really sort of unheard of in a drug trial. And later work actually found that when you actually tally up all of the costs, including the costs for pharmacist training, for incentives for the patrons, for pharmacist driving hours, all of the costs, that when you do that, it still came out as a cost-effective intervention. And the conclusion from this team, and actually we are actually working with some of the folks who did this analysis, Dr. Andrew Moran at Columbia, actually was the senior author for this work. But what they concluded was that payers should be willing to pay about $1,400 per patient year enrolled in the program. And what we see is the longer you go out, right, the larger the benefits, which are depicted in the blue lines. So this idea of going to the barbershops and bringing not only blood pressure measurement, but also medication initiation into the barbershop, that it can have tremendous results for public health and the prevention of cardiovascular disease. So what are the keys to success for the barbershop-based approaches that I have outlined here? One is closing the community to clinic loop, right? We know that the healthcare setting is not a place that many people like to go. And so to the extent that we can start in the community and have a community-centric model as opposed to a clinic-centric model, we really do heighten our chances of really building on and leveraging the trust that exists in the community to even start some of those conversations. Multi-level buy-in and a team-based approach. The success that we saw was because there were multiple partners involved, from the barbers to the primary care providers to the Siri, sorry. Let me put her away. And so really making sure that it's a team-based approach, and again, that team-based approach is community-centric. And so community-centeredness and addressing the social determinants of health. These are really the sort of three keys to a barbershop-based approach. So what I've shown you are all efficacy studies, right? They have all been done sort of in ideal sort of research conditions, even though they have been done outside of a laboratory, so to speak. They still have been efficacy or effectiveness studies. And so we believe that we are at a point where, we have several evidence-based approaches that are rooted and really anchored in barbershops. But now, what can we do to really take this to the next level? And how can we actually implement this outside of a research context and in a more of a real world context? And so that is what I am proud to be doing now with Lisa and with Deidre and with Yvonne. And I see Nancy on the call, and several others as part of the Restore Network. And so I'm going to talk about that in a bit, but I just before I get there, want to talk about how I got started working in Staten Island. So for those of you who are unfamiliar with New York City, New York City is comprised of essentially 5 subdivisions that are known as boroughs. So Manhattan is a borough, Brooklyn is a borough, Bronx, Queens, and Staten Island is another one of those subdivisions. So I was approached by the Staten Island borough president. So each of these subdivisions or boroughs has a borough president. And the Staten Island borough president actually came across a TED talk that I did, and literally tracked me down at NYU and brought me to Staten Island to meet with his health champion, Dr. Ginny Mantello. And really that is sort of how we got started focusing on hypertension in Staten Island. And the reason that this is a sort of a perfect place to do an implementation research study is because of its rich socioeconomic diversity. And so, our feeling was that not only was Staten Island a place that really sort of needed some attention on hypertension among its Black residents, but also, if we can figure out, how to address hypertension and address social barriers in Staten Island, then that can absolutely translate to several other places, both within and outside of New York City. So Staten Island is a place where about 10% of its residents are Black. Nearly 90% of the Black residents that in Staten Island live in this sort of blue, in the blue zip codes, also known as the North Shore. And some of the areas in the North Shore are some of the most socioeconomically disadvantaged areas, which overlay, sadly, as we have seen, in many other cities and other places, those areas of socioeconomic disadvantage overlay perfectly on where we see some of the most stark health inequities as well. And so really privileged to work in Staten Island. And so we started a program called Take the Pressure Off Staten Island. And so this really builds on a program that was actually New York City wide, focused on addressing hypertension in New York City, called Take the Pressure Off. So we teamed up with the Office of the Borough President and Dr. Mantello, as well as the Department of Health in New York City, to really kick this off. And we kicked it off in the COVID year of 2020. So this was a 1-year demonstration project to increase awareness of treatment of hypertension, patterned after the programs that we had done previously. The goals were to increase hypertension awareness, to promote healthy lifestyles, but also to increase linkage for both primary care as well as social barriers. And to do that, we built a network of community and clinical partners. And we basically built on this model here by adding social services, by adding payers, by adding pharmacies, all to a sort of referral network, to really create a sort of umbrella of services to really facilitate men being able to focus on their hypertension identified in the barbershops. And so Take the Pressure Off it began in 2020, as you can tell from the masks here. And we started in the summer of 2020 once we helped the barbershops, which had been shut down like every other business in New York City. So the barbershops were able to actually survive that in Staten Island. We actually helped them to reopen. And once we did, we were able to then, in addition to helping them get back on their feet, to also focus on the health of their customers. We worked with an incredible organization that we continue to work with called Community Health Action of Staten Island. It is an organization that does its work through community health workers to both identify folks with medical and social needs and to connect them to those services. And so, over that COVID year, the CHASI team was out in the community measuring blood pressure and connecting people, both tabling as well as utilizing a mobile van, just as we had done when we first started. And so over that COVID year, we were able to measure blood pressure. So we were able to do outreach and education with nearly 3,000 people. We measured blood pressure on over 1,200 of those people. 800 of the 1,277 readings that we got were elevated, and that's according to the 2017 American Heart Association and American College of Cardiology guidelines for hypertension. A significant number already had a diagnosis of hypertension, and the majority of folks that we engaged consented to us following up and being able to reach back and connect them. We found that about 80% of the people that we engaged had either hypertension or elevated blood pressure, anything equal to or greater than 120/80, and only 22% were normotensive. And so that was really our preliminary data, so to speak, for the project that we're working on now as part of the Restore Network. And so this is a network funded by the American Heart Association, which focuses on addressing social determinants of health to prevent hypertension. So we're basically taking the things that we've learned about hypertension control and really applying those lessons to hypertension prevention, based largely on what we found over that COVID year, and the large number of folks who had elevated blood pressure. So just a word about the Restore Network, which I'm happy to be a part of, which NYU, Columbia, UAB, Hopkins, of course, Wayne State, Tuskegee, BI, and Harvard and Boston, and UCSF. And this network basically includes 5 projects that are all community-based, all focused on hypertension prevention in Black people, and also focused on the social determinants of health, really looking to achieve health equity through the lens of hypertension prevention. Each of these projects is supported by several cores, including a training core, including a community engagement core, which is led by Lisa. And this is our project, the Community to Clinic Linkage Implementation Program in Barbershops, CLIP for short. And this study, it basically is an implementation study. There are basically 3 phases. There's a pre-implementation phase, an implementation phase, and a post-implementation phase. We are using a couple of implementation research frameworks, including RE-AIM, also the Consolidated Framework for Implementation Research. But the idea is that the customer will essentially enter a barbershop, be engaged with getting their blood pressure measured by a community health worker. And the community health worker if they are found to have elevated blood pressure, will refer that person for medical care or make referral for social services, where there will be counseling and referral made to address many of these barriers, which tend to get in the way of people being able to address their health. And we will be looking at the effectiveness of our program on important health behaviors, as well as outcomes like blood pressure. We want to see if we can prevent hypertension, and also at the end of the day, see if what we're doing is cost effective. And so these are the aims of the study: to assess barriers and facilitators for adopting the intervention in barbershops, to essentially scale up and compare in a cluster randomized trial of 20 barbershops the impact of this program on blood pressure reduction and on the prevention of hypertension, and then ultimately to look at the sustainability of what we're doing and look at the cost effectiveness over a 10-year time horizon. A very quick overview of the implementation strategies. In our first aim, we're looking to really look at these consolidated framework for implementation of research domains of outer setting. That's the sort of the outside context, the inner setting, what's happening within the barbershops. What are the characteristics of the interventionists? What are the characteristics of the interventions? And all of this work that we did was to come up with an implementation strategy that will be tested in, that will be implemented and tested in AIM 2. And so this is the implementation phase of CLIP, where we'll be measuring blood pressure in barbershops, but really trying to optimize all of those sort of protocols to come up with a sustainable model, and to really understand, what can we put in place that is going to be best for all of the stakeholders involved, and then to evaluate in all of what we're doing in a way that will not only lead to hypertension prevention, but that will allow us to make the case to important stakeholders down the road. So some of the things that we have accomplished so far in order to get to this implementation strategy, we've convened an implementation committee to develop that strategy. We met over the first year multiple times with a number of key informants, including managed care organizations, community leaders, including a community advisory board that we have that now meets quarterly, also partnering with the local American Heart Association. This is the barbershop strategy that we are implementing. I won't go through this whole thing, but the idea is that a patient navigator or a community health worker who is in the barbershop will approach customers, provide some education, but also see if they're eligible to participate in our study. If after getting their blood pressure measured, they have true hypertension, they get referred for care. If they are eligible for our study, then the community health worker does a number of things, including referring them for care to a provider, delivering lifestyle counseling, providing and linking them to health coaching if the customer has access to that. And in addition, also taking the customers through the research protocols. And Chazzy has done a tremendous job of doing everything that they normally do to improve the lives of their customers, but also doing the research part of this as well. A really, really difficult task. This is some of the co-branded materials that we've come up with our community partners, one of which is what we're calling our project, which is the Blood Pressure Health Justice Program. Our partners felt that this is not just a matter of health equity, but is also a matter of health justice. The fact that we know how to prevent hypertension, the fact that we know how to, even for people who have hypertension, the fact that we know how to prevent the consequences of it, but the fact that still so many Black men are dying from the consequences of it, that's not just a health equity issue, it's a health justice issue, and we all need to do our part to address the health justice around these issues. These are just some sort of snapshots of a social media campaign that we created with our partners. And so you can find us on Instagram by typing in SI Clip and to see some of the things that we have been working on. And so we're now in AIM 2, which is the randomized trial, where we are randomizing 10 shops to the intervention, where there's going to be a barbershop facilitator who's going to be helping to implement these strategies here, and a control group who will not have the facilitator to help implement some of these strategies. And we'll follow these shops for 12 to 18 months to look at the impact on systolic blood pressure, diastolic blood pressure, incident stage 2 hypertension, as well as some of these patient-reported outcomes listed here, including linkage to care. So I have talked longer than I intended to, but I am really, really grateful for this opportunity, and also grateful for your attention. And I look forward to any questions that you have. Thank you very much.
Well, thank you. That was a fabulous tour de force. So, and you will see in the chat that it's quite alive with people just admiring your work, and there are also lots of questions. And so, given that I think we have time to try to get through them, but I'm gonna try to help us march through many of them so that we can hopefully get all the questions answered that people have. So first, I'm scrolling first through the comments about your many talents to get to the questions. So you'll have to take a look at that when you have a moment. But one of the first questions that came up from Rhonda Ford Chapman was whether you were able to incorporate COVID vaccinations in any of your work. And she was commenting that we saw some of that type of effort in Maryland, and was wondering if you did something similar in New York.
So yes, absolutely. Thank you for that question. Yes, we absolutely did, and really because this work in Staten Island really started in 2020, COVID was the priority, and so addressing vaccine deliberation was certainly something that our team did, and the barbershop was an incredible place for us to do that. And so the short answer to your question is yes. Even though that wasn't the primary focus of what we were doing, one of the things that I think has been part of the success of our work is really deferring to what's important to our barbers and to our barbershops. And because COVID was top of mind, that for them, it was top of mind for us as well. Thank you. I thank you for giving me the opportunity to share that.
That's great. So I think you touched on this a bit, but there was a question from Deja Love Hardnett about the type of qualitative data that you have, like from the barbers and the research participants based upon the experiences they have.
Yes. Great question. So we do have a qualitative data, both from customers and from barbers, and and I could probably talk for another hour just about that, but I promise I will spare you that. Generally speaking, customers love what we're doing, and I think that really speaks to the very high EQ of the people that we have in the barbershops, who know when to push and when to back off. And so overall, customers, really enjoy the opportunity to engage with us. Barbers also generally enjoy in engaging with us. There were definitely instances where we felt that some barbers felt that what we were doing was getting in the way of what they were there to do, which is to cut hair and to, and to not talk about serious things like, strokes and heart attacks. And so, so, we were always very vigilant and really deferring at all times to the wishes of the barbers. But overall positive, but as you can imagine, there's some variation that was also dependent on some of the shop factors. The older shops are definitely generally more accepting of these health oriented things. The younger shops where young people generally don't think that they're invincible, and talking to them about things that are going to happen to them 5, 10, 20 years down the road is often are not things that they want to hear about. So yeah.
Oh, that's interesting. So let's see. So Deja had a couple of other questions. Maybe I can group them together. One of them was one that I also had, which was about how can this model be replicated, and whether or not you've approached payers about this, and to think about who might, for example, fund the services of the pharmacist.
Yeah, great
pause with that
question.
one, and we can come back to the other.
Yes, great question. So one of the I think core functions of this Restore network is to really think about scale. And so at a Restore network level, there are our colleagues have engaged with the Googles of the world, and other sort of large organizations like that. Obviously, the American Heart Association is a big partner in this, and we've been talking with their national leadership, and in fact Lisa and Yvonne were actually here a few weeks ago as we talked with the National American Heart Association leadership about precisely some of those questions of scalability and sustainability. And so we're engaging with payers, both nationally and locally, particularly in Staten Island. Myself and my community champion, Dr. Jenny Mantello, we meet quarterly with 4 payers here in Staten Island, really trying to think about what it would take for them to basically take on some of this. And it's been really interesting to sort of have to think very concretely about what does it look like for a payer to actually support this. And we're sort of starting small, saying, well, if you can support paying for one community health worker, that actually goes a really long ways, and we can start there. Also thinking about how can we incentivize barbers and barbershops to not only want to house this in their shops, but also to actually participate and to actually measure blood pressure. All of those things are things that we are very actively thinking about, trying to make the best case possible to the multiple stakeholders.
Oh, that's terrific. I wanted to see if give our center director, Dr. Cooper, the privilege of asking her question. So if she wanted to, I don't know if Lisa, did you want to ask your question about facilitation?
I think something's wrong with her Zoom. Is she on?
Oh, with her Zoom. Oh, okay. Yeah, maybe we lost her for a bit.
I think we lost her.
Okay, I can come back to that. Lots of compliments. Let me come back to another question from Deja Love Hardnett, which was about the process of getting the various stakeholders involved. Wondering if you could share a little bit more about the process that you undertook to get the various community stakeholders involved in a productive way, and what helped you to do this so well?
Yeah. Great question. I learned, very early on to not reinvent the wheel. And so I've just been very fortunate in both, in both Dallas and in New York City to have been able to find the people who are already connected and to connect with those people. And so here in New York City, I connected with, when I first came, connected with a woman, her name is Marion Scott, who at the time was the head of community and government affairs at St. Luke's Hospital. And she's been in this community health promotion game in New York City forever. And she just knows everybody. And so it was really through her that I met several community leaders, was introduced to several barbers and barbershops. And so, really connecting with trusted people, I would say is definitely the best way to go. Now, that said, it's a very, you have to be a really good steward of those relationships that they have entrusted you with, because you are, you're really sort of leveraging their good name, and I take that so seriously, realizing that how I treat these partners, and if I don't do right by them, that really, that could have dire consequences. And so I think I approach this with lots of humility, knowing that I didn't build these relationships on my own, and that I have to take great care to really to make sure that when people sort of welcome us into their homes, so to speak, that we are the best guests possible.
Oh, great advice. And definitely applies to a lot of the work we have on, a lot of the relationships that we're continuing to try to cultivate at our center as well. So Patty Dash asked a question that's very near and dear to my heart, so I definitely want to lift it up. She says that at the National Kidney Foundation that we've discussed engagement with barbershops, and she's curious as to how outreach and screenings for kidney disease might resonate with the sort of barbers and clients that you work with. And she said she'd love to speak with you further about it, but curious if you could comment about whether you touched on that.
Absolutely. Thank you, Patty. I think it would resonate tremendously. So one thing that I hope I was able to demonstrate is that we've been able to sort of start with hypertension, but then go in a bunch of other different directions. And so one of the directions that we started to go in is actually focusing on diabetes and pre-diabetes and doing finger sticks in the barbershop. And that actually played very, very well. We saw a high level of acceptability for doing that. One of the most striking memories that I have from Dallas, Texas is, going into a neighborhood shopping mall and seeing 6 dialysis centers in a shopping mall in one of the Black communities in Dallas. So I say that to say, just as much as, if you are a Black person, someone with hypertension, almost certainly if you're a Black person, something with end-stage kidney disease who's on dialysis. And absolutely, I think it would resonate tremendously. And because hypertension, as we know, is such an important etiologic factor, it's not a very far distance at all to include chronic kidney disease and end-stage renal disease in what we focus on.
Well, that's great. And tomorrow is World Kidney Day, actually. And the statistic I think that would apply to your work is 1 in 8 Black men will develop kidney failure in their lifetime. So just a tremendous burden. So I definitely would be excited about talking more along with Patty about that idea. So we have Dr. Cooper back. We wanted to give you a chance to ask your question.
Yeah,
You had.
can't believe Zoom kicks me out there for a little bit. Joe, I was just wondering, I don't know if anyone asked while I was off,
but if you could share a little bit more about what the facilitation process is and who that person is and basically what they do with the barbers.
Yeah. Great question. So facilitation really comes from something known as practice of facilitation, which is a clinical model where essentially an external expert sort of comes into a practice, and for whatever a given outcome is. So let's say it's hypertension control, right? If you want to improve hypertension control in a practice, right? A facilitator basically comes in and observes all of the processes in that practice related to hypertension control. So, and so how many people with hypertension are coming in for follow-up? How many people are being titrated on their medications? How many people are being referred for therapeutic lifestyle changes? So on and so forth. And based on what the facilitator observes, basically giving recommendations about how things within the practice can be optimized to better achieve that goal. So we basically took that idea, and rather than a practice facilitator, we have a barbershop facilitator who is looking to optimize procedures within the barbershops related to getting customers to get their blood pressure measured and referring those customers for either social services or for medical care in order to prevent the development of hypertension. And so the facilitators, they only deal with the intervention shops, and the frequency with which they go is sort of it depends on the shop, but it's sort of it's something that they work out with the community health workers and with the barbers. And it really is a very sort of collaborative process where the facilitator says, hey, might say to the community health worker who's working in the intervention shop, hey, I noticed that when you approached Mr. Jackson, you said XYZ. If you said ABC, they might be more willing to get their blood pressure measured. Why don't we try that? And so the community health worker says, oh, thank you for the advice. They basically try it. And then the next week, the facilitator checks in and says, hey, how did that go? And there's basically a whole facilitation checklist like that of things that the facilitator is looking for and recommendations to make to basically optimize what's happening in those barbershops. And so it is an iterative process where we're really sort of figuring out, it's pretty early on, so we're figuring out exactly what it's going to look like in all the shops, but that's the idea.
Oh, that's great.
Yeah, I'm familiar with the model, but I wanted to make sure other people heard about it too, because I think it's an interesting sort of addition, like another layer sort of an intervention, above just sort of going there and like saying, okay, barbers, community health workers, here's all the stuff, good luck, and we'll talk to you when it's all over.
Absolutely. And that's so on point, Lisa. And I think what we realize is, if there's going to be sustainability, it has to be something that each shop is bought into and that they own. And we think that facilitation is one way to ensure that these barbershops and barbers actually own the intervention.
Oh, well, this has been absolutely wonderful. So please everybody join me either in a way that we can hear you or via the chat in thanking Dr. Ravenell for really a fabulous talk and even more fabulous work that really is helping it advance areas that so many of us care deeply about. So thank you so much, and thank all of you for being so engaged in the chat and otherwise during this time together today. So we will see you next month on April the 12th, which is a special day for our center director. Who
unfortunately won't be with you that day, but
But we will have our jam session and celebrate her birthday.
Oh, happy
in her
birthday.
absence. But we will see you all back then. So thanks again.
All right.
Bye, everybody.
All right.
Thanks again, Joe.